invite Professor Hahn. He'll talk about the urine analysis of dehydration in surgery and in the elderly. Please, Professor Hahn.
So change. I speak here. You can hear me. Thank you so much for inviting me to this meeting. It's my first time to this SMART event, so it's very interesting to see how these 3 days will work out. My name is Robert Hahn. I come from Stockholm, Sweden, and I work currently at this hospital in the southern outskirts of the area, but this is the city center, of course. This is what it looks at this time of the year. Now, I'll try a little different approach to this topic, and we'll speak about urine analysis, if there's any approach here that can perhaps be useful in giving us more knowledge about this topic. Okay, when there's dehydration, the key target organ here is the kidney, of course, and it starts to concentrate the urine by conserving water, but at the same time there are several components, metabolic waste products that are continued to be excreted or more or less concentrate. You can measure many things here. You can measure metals. There are several of them that are appear in higher concentrations when there is renal fluid conservation, but they have certain measurements that you can perform bedside, easy to access, and creatinine is one of them. It's a remnant, as you know, of muscle metabolism. Urine color is another one. Osmolality, of course, and urine-specific weight. And these appear in higher concentrations if we have dehydration. And the first ones to work with this were actually working in sports medicine. This was the first paper I came across, 25 years old, and researchers then subjected athletes, male athletes in their early 20s, to strenuous exercise, and they measured changes in body weight and then how the urine composition changed and also what happened to blood parameters. And they found that urine color, osmolality, and specific gravity in the urine correlated closely and was more sensitive to dehydration than serum osmolality. And they actually constructed this color scale that you see here that's available on the net. It is intended for sports medicine then. And there were several papers in the 1990s working with this, trying to make it into a system, sort of correlating specific values of urine color according to this scale and urine-specific weight to a change in body weight. And in short, if the color was darker than 4, that was to indicate a loss of 3% of the body weight. And that is, in sports medicine, at least indicating dehydration. Now, I did a study myself a couple of years ago in cross-country runners. And what was good with that was that I extended it to females, and I took older people up to 70 years of age, and they behaved pretty much the same, so that we could see that there were close correlations then between these markers, more or less good. I think the best were between creatinine concentration and osmolality. I put together what I call a fluid retention scale just to make this kind of diagnosis more robust. And it was the idea here was to give every value in among these 4 marker by markers of fluid retention, a score, and then you took the mean of all the scores. And the reason for doing that was that in particular in hospital care, there are outliers. So we can assume that certain patients have urine infection, for instance, that makes their urine more dark. And there could be other problems with their health. It could be medication and so on that changes things. So if we say that we have a specific gravity here of 1.015, osmolality here, creatinine of perhaps 6.5, and then we have urine color of 6, then we should exclude this as an outlier. And I put a kind of system for exclusion so that you get a fluid retention index value that would describe this, the degree of fluid retention as well as possible. I put together many studies that were done mostly in the 1990s of sportsmen and constructed a scale here so that we could see that the FRI, the fluid retention score, correlated pretty well to a known weight loss. The open squares here are actually my data from different populations. But this is something that one can say is pretty well established then, at least in sports medicine. Now taking this to hospital care makes it a little more difficult. But it's a long story. We should start with just some data here from the geriatric section. And we have this study was done in my department. We measured urine in the morning in 256 elderly patients admitted to acute geriatric care. Like in my hospital, we have a lot of acute geriatric care. And we calculated this fluid retention index, and we found that dehydration was not so common, about 15%, but they had a 3 times higher short-term mortality compared to those who were not conserving water. And this was within the first month after admission. So I followed this for 1 year, and it did not get worse. Actually, the difference between the two groups became a little less with time. But this was a very acute issue. At about the same time, another study appeared from England. They did about the same thing. Patients aged about 80 years. Although they didn't measure the urine, they took the serum osmolality exceeding 300 milliosmoles per kilo. That's a blood parameter that you can use. And they found it to be a 6 times higher likelihood of death in the hospital if the serum osmolality was high compared to if it was below 300 milliosmoles per kilo. Okay, if we go to surgery, we had one study here, concentrated urine. We didn't measure fluid retention index here, but only urine-specific gravity, and that's renal fluid retention is if you have more than 1.020 or higher, then we have fluid retention. And it appeared that the postoperative complications were 3 times more common in those that had fluid retention compared to those who did not have that. So there was a very marked difference. Although the groups were not very large, 45 patients, we could see this difference. Yeah, what happens to the fluid handling? This is a study, experimental study in volunteers where they were given fairly small amounts of Ringer's acetate over 15 minutes. But in half of these 40 experiments, they were made dehydrated by administration of furosemide. Yeah. 1.7 liters was lost, and we can see that plasma volume expansion, or taken as the plasma dilution based on hemoglobin, it was indicated that the plasma volume was larger in the presence of dehydration. This is another one in old patients, 75 years, from the urology department, and if there was fluid retention, plasma volume expansion was 3 times greater than if we didn't have this fluid retention situation. Okay, what about induction of general anesthesia? This is a Chinese material that I helped to write up. This is a stroke volume index before anesthesia was induced, and then we go up and down here when we intubate. But here, 3 successive bolus infusions were given containing either ringers or starch. And no account was taken of the result, we just gave them. So one could see when did the patient become fluid optimized. That's about 100 patients in that study. And it showed this, like those who did not need they were fluid optimized to begin with, or they needed 1 bolus to be fluid optimized, so to speak, that the stroke volume index didn't increase more than 10% as a result of the bolus. They had not as concentrated urine as those who needed 2 to 3 bolus infusions. And in particular, we can see that in the creatinine, difference in the creatinine level. We could actually see that in the cardiac index at baseline too, suggesting that this group actually was a bit hypovolemic. We couldn't see it at all on the mean arterial pressure or CVP. So it seems like if you need volume optimization in the beginning of surgery, it can be detected by urine excretion. Now this is a small study, sorry, it's still a quite small study, about 100 patients, and the preoperative fluid retention index, here you see 3.6. If starch was given during the first hour, this didn't change, so it was the same value. But if we gave Ringer's acetate, there was a reduction to 2.8, and the high values for this fluid retention index during the first hour was clearly when the rate of urine excretion was less than 100 milliliters. You can see here, for instance, creatinine concentration really went to very high levels. So I always wondered how high can it become? I've never seen higher than I think 40 is the highest I've ever seen. It doesn't seem to be higher. But the other markers followed quite nicely. It's an observation from this study. I took a look at those who had an increase in serum creatinine as a result of these operations that were cancer surgery lasting for 3 to 4 hours, and we focused on the first hour. As you can see, those who had an increase in serum creatinine after operation did have a higher fluid retention index to begin with. Urine flow didn't differ very much, but you can see that the creatinine clearance was very high in these patients during the first hour of the operation. So my interpretation of that, maybe I can help from the experts, but I interpret this that the kidneys really strive very, very hard to excrete creatinine. But eventually they didn't, the kidneys did not succeed as we had a postoperative rise in the creatinine. I don't know what happened later with them, but something must have happened because I assume that this must have gone down with the development of the acute kidney injury. All right, as a time to sum up, this is a kind of different approach from the ones that you've seen or heard about earlier in this symposium, but urine can be analyzed and we can have a robust measure of fluid retention. most often I see in patients who we see, this is due to dehydration, but I'm sure it can be due to other things as stress. And of course, you must evaluate that some patients may have disease that affects this, like heart failure, for instance. I would be very careful with using this measurement alone to detect dehydration. Okay, so it's quite sensitive. And we can conclude from what I've said that it clearly affects the body's handling of infusion fluids, and this is not acknowledged before, as well as far as I know. In the old patients, it seems to indicate an increased mortality within a short period of time. This is not a long-term thing, it's an acute risk. And in the old patients undergoing surgery, it might indicate risk of postoperative complications. But we really don't know how this should be placed in medicine so far. But these are some of the first steps to make it useful. So thank you.
Thank you very much for the